can use this to put the slides.
Okay, this one? Yes. Okay, great. You're on? Well, while they're setting up my slides, I just want to say what I'm going to talk about. I'm going to talk about the placebo and the components of the placebo. I guess that's not a surprise to anyone that's here. What I did was select one of the studies I did, and my colleagues did, that I think illuminates the question in a clinical setting, in the setting of a randomized controlled trial. Yesterday morning, I added 2 more slides on history because we want to contextualize this whole question. And then this morning, I added 3 slides to dealing with criticisms of the major study that I want to present. So that's what I'm going to do today. The word placebo that we use today is directly tied linearly to the word St. Jerome's translation of the 114th Psalm, or what the Catholics consider the 114th Psalm. Placebo domino in regno favorum. Sorry, I will please the Lord. I will please the Lord in the land of the living. The reason how this became associated with what we call placebo now is that in the Middle Ages, people during a Mass for the dead, people would chant the 9th line, which is, I will please the Lord in the land of the living, and wait for the funeral Mass to begin. Rich people would hire friends, they would hire professional mourners to wail and cry as they're singing the 9th line, waiting for the Mass. And those people were called placebos, fakes and duds. Therefore, the nefarious connection between placebo and fakeness. Later on, Chaucer mentions placebo many times. One of his central characters in Canterbury Tales is Mr. Placebo, and you wouldn't want to be a friend of his. Placebos became the word that was identified with fake medicines in the 19th and 20th century. This is a quote by Richard Cabot, 1903. Does anyone recognize his name? Can I see a show of hands? Good, thank you. Oh, good. You got it, right? Okay, if you could. Everyone who reads the New England Journal every week sees his name, a clinical pathological rounds. The column has his name on it. This was the most prominent physician at Harvard Medical School at that moment, one of the 2 or 3 great physicians at that time. This is what he wrote in 1903. I wish I was brought up, as I suppose every physician is, to use placebo bread pills, water subcutaneously, and other devices. I doubt if there's a physician in this room who has not used them and used them pretty often. I used to give them by the bushels to ignorant patients. Basically, the placebo was used for malingerers. It had no effect. Obviously, something that has inert water has no effect in most situations. And it was basically a dud. If you had a response, it's because you were gullible. This totally changes in the post-war period in the 20th century after the Second World War, when the new development of the randomized controlled trial, comparators, develops. And basically, if you compare 2 arms identical except for the one arm having the real exposure, if there's a difference, you have an effect. The placebo is used as a comparator. Originally began as a device for retention and recruitment, but by the 50s, early 60s, people saying, oh my God, there's an effect in that placebo, and thus the name the placebo effect, which is actually coined by Stuart Wolf in 1950. It's an oxymoron, right? The effect of something that's inert. And more important, it's an occult phenomenon. What is this effect, right? For placebo researchers, this is not very helpful to say placebo has an effect and it's a randomized controlled trial. And let me show you what I mean. Do I have a laser on that? Okay, well, it's okay. I'll try without.
I think you pressed that, no?
Bill, you're always smarter than me in college, too. So what's inside, for a placebo researcher's perspective, what's inside the placebo arm of a randomized controlled trial? Yeah. Oh, no, it's okay. I wanted this one now. So one of the things inside is fake pills, fake injections, even fake surgery, right? That's a psychosocial effect of the ritual of medicine. That's a placebo effect. Also inside the placebo control arm is the patient-practitioner relationship. Calling it placebo is not really makes most people comfortable, but in fact, that's what's a psychosocial effect of the ritual of medicine. It's in the placebo arm. You can call that a placebo effect. Oops, spontaneous remission. Clearly not a placebo effect. Is in that arm. Regression to the mean, right? You select abnormality, you do a second subsequent reading, and the average it returns to the mean. That's not a placebo effect. That's the way statistics and measurement artifacts happen. Natural fluctuations, a person gets better or worse, that's not a placebo effect. That's just getting better or worse. Misclassification is something we don't pay attention to. You're in a randomized controlled trial. The patient is in front of you, and you go, are they eligible or not? And then you say, oh, this, and then you remember your project officer at the NIH who's looking down at your recruitment and say, yeah, they're eligible. When they get better, that's not because of a placebo effect. That's misclassification. It happens more often than we imagine. And also physical co-interventions. You eat a little better, you rest a little better. That's not a placebo effect. That's a co-intervention. So the question for placebo researchers is how do we control for this to study this, right? So what we do is, and if I can call it, the true arm, the Virum arm, has noise in it from a placebo perspective. The placebo has noise in it. How do we control that noise to find that a genuine placebo effect? Everyone see that? And there are two ways of doing it. One is a no treatment control. No treatment would, no treatment would control for spontaneous remission and regression, a waitlist control. Everyone see that? Another way of doing that, dealing with noise is a dose-dependent relationship. You give 10 milligrams of a drug compared to 5 milligrams of the drug. If there's no difference and everything else is identical, the comparison of 5 and 10 milligrams is a way of controlling for noise, and it's dealing with it's a way of controlling for that kind of for the noise of the placebo effect. This is the slide we used to explain the trial I'm going to present, which is the focus of this talk. I want you to take this placebo 2 times a day for 10 days. If your condition doesn't improve, I'd like to give you a stronger one. We decided when we put in this application to the NIH that we really want to see we wanted to really nail, is there a placebo effect or not? We picked an illness that reputedly has a large placebo effect, irritable bowel, and we decided to control the question with 2 controls. One is, could we incrementally increase components of the placebo effect in a way that's analogous to dose-dependent? We're going to try to do a dose-dependence trial. And we want to control it with a no treatment control. Both would control for noise. Everyone see that, I hope? The paper was published in BMJ in 2008. The study was fun. Bill, you definitely are more intelligent than me.
It's very true.
For dyslexics, it is. I can't believe that I knew you that long ago. That's really interesting. So we randomized 262 patients with irritable bowel syndrome to a no treatment control. Did nothing except do assessments for 3 weeks. And then at 3 weeks, they continued for a follow-up of 3 more weeks. We had the second arm with what we call the limited placebo. I'll show the placebo. We used the placebo acupuncture needle. I'll show it in a minute. What we did was the practitioner came to the patient and said, hi, I read the intake, I read the forms, I know exactly what to do. But I've been told not to interact with you. Keep it to an absolute minimum because we're studying acupuncture and we don't want the doctor-patient relationship to affect the outcome. We obliterated, to the extent humanly possible, the doctor-patient relationship. There was almost no talk. The only talk was, get on the table, please get off the table. If I'm getting better, please talk. And we told the practitioner said, if you have any questions, talk to the physician in charge, talk to the nurse in charge, talk to the research coordinator. There was no placebo, no doctor-patient relations in that arm. And this is going to go on all day, huh? And they proceeded to give 6 acupuncture treatments over a 3-week time. At 3 weeks, again, with no doctor-patient, there were a random relationship. Patients were re-randomized to continue on placebo acupuncture, no limited interaction, or genuine acupuncture. We had to have genuine acupuncture because we had to advertise this as an acupuncture study. You couldn't advertise it as a placebo study. And the IRB was fine with that. But we did have to debrief all patients at the end. And this became a secondary nested study that's not reported in this primary paper. At the third arm was what we call the augmented placebo. The practitioner came in and said, hi, my name is, tell me what's going on. we asked the practitioner to do a short medical history, a short psychosocial history, and a short interactive biographic discussion. So what does this feel like in terms of your life in general? What do you think this is about? And we asked the practitioner to do 5 behaviors. And the entire trial is being filmed from beginning to end to make sure that they did what we told them to do. And the 5 behaviors they had to do, the practitioner, was attentive listening, repeat the words of the patient, empathy. I know how this feels. My brother, sister has this. Confidence. I'm very excited to be in this trial because I know acupuncture I've treated many people with irritable bowel with acupuncture. I know it works. I want to show the medical community it works. 4, they had to touch the patient, either the pulse, abdomen, or the shoulder, some way show it. And finally, they had to say to the patient at some point, you know, I'm listening to you. I think I understand. Give me 20 seconds to think about it. Right? We read that in a great book on the doctor-patient account way. And it was a real schmaltzy, standardized intake. And and they did 6 acupuncture treatments, the same treatments as this for over 3 weeks. And then at 3 weeks, they re-randomized patients to either real acupuncture, which we put to another study, or follow-up of the same continuation on placebo treatment. The needle is really cool. This is a real needle. This is a real needle going in. It penetrates the skin. The placebo needle is like a dagger in magic sword. You stick it in, you see it go in, you feel it go in, it stands up, but actually went up the shaft. It doesn't penetrate the skin. We used it over non-acupuncture points. When I was first saw the needle and looking for a good placebo, when they did it to me, the inventor, I said, you made a mistake, you gave me real needles. It's a really clever placebo. We use the 4 standard IBS measures or questionnaires that the FDA at that time required for drug approval. The IBS adequate relief is a binary. In the last 7 days, have you received adequate relief? The global improvement is a 7-point scale from -3 to +3. How much improvement you had in the last 10 days. The symptom severity scale is a 5-item scale, each scale 100 points, having to do with severity of pain, frequency of pain, frequency of distension, satisfaction with stool, and quality of life. And the last questionnaire is a validated IBS questionnaire for quality of life. Can you go to movies? Can you go to a restaurant? Can you drink wine? Our hypothesis was that the wait list would be less than the limited, and the limited would be less than the augmented, and there would be a monotonic relationship showing some kind of the components actually increasing or with the increase of the components of placebo effect. Making sure I got that. The results were better than we could expect. We got a monotonic relationship on all 4 outcomes. That was our primary analysis. The p-values on all 4 are less than 0.001. Just to show you intuitive, so we only have a little bit of time, the easiest one to see is the adequate relief. By just sitting there, just with noise, spontaneous remission, regression to mean, natural fluctuation, about 27% of the people reported adequate relief. That's our no treatment control. With just the dummy treatment, we got about 47% of people saying they got adequate relief. And then when we added the doctor-patient relationship, it shot up to 62%. It's pretty nicely done. All the pairwise comparisons are significant. Post-hoc pairwise comparisons are significant, except for these 2 and this 2, suggesting that the doctor-patient relationship gives the biggest oomph for the buck. At 6 weeks, we had it's the same thing held. It's interesting. The effect size of 62% is comparable to elastotron and tagaceride studies when the meta-analysis that were published in Lancet in 2000. We had many other embedded studies. For instance, we took another 27 patients, 9 in each arm, and had anthropologists interview patients at baseline, midpoint, endpoint, and psychologists. we had sociologists. We've published 10 papers so far. We're submitting tomorrow our first genetics paper. We got money from the NIH. We had blood samples of all the patients, half of whom gave us genetic informed consent. That's going to be submitted tomorrow. And we've done neuroimaging on that placebo needle on healthy volunteers in laboratory settings, showing that there's, when people get a placebo response to this needle, there's objective changes in the brain that correlate with relevant areas that you would expect. Oh, well, there are two criticisms of this study. This is great. I'm going to finish on time. There are two major criticisms of this study. This is from the BID where the study was done. Mr. Jones realized that you guys cured him with a placebo, but he paid us in play money. I think that wasn't a good criticism. The reason is that we had two NIH R01s and one R21 to pay for the main study and the subsequent studies. The BID got its money. And anyways, criticizing something for being cheap is not a good criticism in this environment. So that was the one main criticism. There were many others. But there's another criticism that was very important. People said to me, Ted, I don't buy this study. So what? This is irritable bowel is, it's a disease that's a leftover. It's by exclusion, right? It's a functional bowel pain syndrome. There's no objective markers. What's the big deal here? Okay, it looks like you've nailed it from two directions, but don't buy it. I personally don't buy that criticism because I think medicine is deeply involved in patient self-appraisal, in what patient-centered symptoms, things like pain, things like fatigue, insomnia, anxiety and depression are a very important component of what our patients come to us for. So I don't buy that entirely, but as a placebo researcher, that criticism is very important. Does the placebo change objective pathophysiology? What's the evidence? And as a placebo researcher, I want to know how big a banner do I wave, saying this is important, right? By the way, we do have objective neurophysiological correlates with placebo. I mentioned neuroimaging, but also we know that many neurotransmitters are involved in placebo effects that are subjective. For instance, endorphins, dopamine, and 3 months ago, in Nature Neuroscience, the CB1 cannabinoids were clearly implicated in placebo responses. So there is a biology there, but there are objective correlates to subjective experiences, but does it change pathophysiology? So in order to answer that question, we performed a second study, which I'll present briefly. I'm not going to go into details, where we had two outcomes. We picked asthma. My colleagues aren't here. Let's see, but I'll show their pictures at the end. We picked two outcomes, FEV1, a sort of objective outcome, and how much, a 10-point, 11-point scale, how much do you feel better from this treatment that we're giving you in asthma? The reason we picked asthma is that I thought if there was an objective placebo response, it would be in asthma because there's a lot of preliminary claims that have been made about that, and I was hopeful we'd find an objective placebo response. The paper was published last summer at the New England Journal. And the study is complicated. Because I want to make sure that we have plenty of time for questions, I'm going to do it really brief. Basically, we brought patients in, 40 patients. We made sure that their asthma was reversible before the start of the study. That is, we told them to go off their long-term medications for bronchodilators for 24 hours, their short-term medications for 8 hours. We brought them into the lab, and we gave them albuterol. It was reversible at least 12%. They were eligible for the study. And then we brought them back 12 different times. We took them off their medications 12 different times, each patient. This is a within-subject study, 480 observations. And we randomized them to 3 blocks. Each block had 4 conditions. A real bronchial dilator, albuterol, an inhaled, fake albuterol, fake inhalator, fake acupuncture, and no intervention. And then this was randomly given to patients, and it was done, 4 interventions or conditions were done 3 times. So it's 12 interventions, about 480 observations. And what happened was really interesting. On FEV1, This is without the median. They sat in the laboratory for 2 hours. Every 20 minutes, we measured their FEV1 and took their subjective ratings, and then we averaged them. 20% of the patients at 2 hours, a mean of 20% of the patients experienced improvement in FE1, right? Of at least 12 or more percent. On placebo inhalators, 7.5. On placebo acupuncture, 7.5. No intervention, 7.5. Everyone see what happened? What happened is there's no placebo effect, right? The placebos are no different than sitting in the room and doing nothing, spontaneous remission, regression to the mean, natural fluctuations, okay? And there's a large drug effect. So we're sitting in the room. This study was at the Brigham in the laboratory of Elliot Israel, led by Michael Weschler. And we were pretty upset that all that work didn't do anything. And luckily, our statistician was there, and I asked John Kelly, bring out the other questionnaire. This is what happened. There was a 50% mean improvement when people took the albuterol. There was 45% improvement when they took placebo albuterol. There was a 45% improvement with placebo acupuncture and 20% improvement with a weightless no intervention control. What happened here is, everyone see what happened? There's no drug effect. The drug did not provide an incremental improvement more than the placebo effect. The ritual of medicine, just performing the symbols of medicine, actually didn't produce, was as good as the real drug in a questionnaire of self-assessment. And it was a very large placebo effect. All three of these were better than placebo. What this suggests to me, I'm going to end in about 2 or 3 minutes. I think there's plenty of time. 1 minute, actually. What this suggests to me that the evidence right now, does placebos change objective pathology? In this particular experiment, obviously you'd have to replicate it in this experiment and in many other conditions, but there isn't good evidence that a placebo treatment, the symbols of medicine, the rituals of medicine, the doctor-patient relationship is going to change objective pathology. But there's very good evidence that's very clear in this experiment that those ritual components of medicine, the non-specific components that are tied to what we call placebo effect, can affect self-appraisal. I think that this doesn't eliminate the possibility that if someone gets better pain or less depression, they change their behaviors, and that could lead to a cascade of some improvements in pathophysiology. But that's speculation. I don't know. So with that, I think I'm going to summarize, and then I'll show some pictures. Am I right? Yeah. I want to summarize what I've said so far is that it seems that there's a placebo effect. It seems that it has effects on symptoms and conditions of self-appraisal. One can break it apart into components. There's not much evidence that it's going to change objective pathology, at least initially at all. And what else did I say? That's the bottom line, did I say? And there's a lot more work to be done, especially mechanistically, and I didn't have time to present that. I just want to present pictures of some of my colleagues. This is the IBS. This is Dr. Lembo at the BI, who is our dual PI in this study, and the chief GI doctor. This is Peter Goldman, our senior mentor. Roger Davis, our chief statistician. Effie Coco runs our lab now that's looking at proteomics and genomics, and the rest are other people in our trial. There's a picture of Michael Wexler, who was the first author on our New England Journal paper. This is Elliot Israel, who was a senior pulmonologist on that paper. And that's what I want to say. I want to thank you very much for listening. Thank you.